Hello, and welcome to today's Healthcare IT News webinar, Building the Underlying Infrastructure of a State-of-the-Art Children's Hospital, sponsored by Juniper Networks. A hospital's network is the backbone of its infrastructure. The new network enables caregiver mobility, connects the care ecosystem comprising people and machines, and provides a platform for new care models, all while robustly safeguarding sensitive patient and medical data. Hospitals can run existing and future clinical applications to provide outstanding patient care and to optimize the clinician experience. Now, this is exactly what a new state-of-the-art 23-story children's hospital considered while building their new infrastructure. During this webinar, we will discuss how a top children's hospital is leveraging this state-of-the-art network to improve patient outcomes, improved access to care, and reduce cost. Our first speaker today will be Jen Pulsifer, the Director of Healthcare Industry Principal at Juniper Networks. Jen is responsible for sales, readiness, and channel enablement, healthcare thought leadership, strategic positioning, and industry and analyst messaging, leading the Juniper healthcare community of interest and establishing, nurturing key partnerships and alliances within the industry. Our second speaker will be Ron Isbell, Assistant Director for Network Infrastructure, Data Security, and User Access at Ann and Robert H. Lurie Children's Hospital of Chicago. Ron is responsible for aligning strategy and maintaining daily operations and security for a multifaceted life and mission-critical campus network infrastructure. Our final speaker today will be David Anseles, Director of Network Architecture at Maron Structure Technologies. As lead architect on the Lurie Children's Hospital build, David led the Maron team in architecting and engineering the Lurie infrastructure design for a mission-critical environment. Now I'd like to hand it off to Jen to begin our presentation.
Very good. Thank you so much, Mike, for that wonderful introduction. And thank you all very much for attending today. I know I'm thrilled to be here discussing an often overlooked component of the health IT ecosystem, the network. As Mike mentioned, my name is Jen Pulsifer. And for those of you who are not familiar with Juniper Networks, we are a pure-play network infrastructure and network security manufacturer. We provide the underpinning technology for the world's most demanding and mission-critical businesses, and healthcare, particularly children's healthcare, is an area where the mission could not be more critical. In a few minutes, you're going to hear from Ron at Lurie about how he and his team are leveraging a state-of-the-art Juniper network to improve patient outcomes, reduce costs, and increase access to care. We're also going to hear from our healthcare accredited partner, Maron Structure Technologies, about the integration services that they deliver to Lurie to make that vision a reality. But for now, before we do that, I'll just show you quickly the agenda here so you can see the topics that we'll be discussing. For now, I'm going to issue each of you a challenge. I challenge you to look at health IT today through a different lens. Consider that there is an overlooked component to your IT infrastructure. In our view, it's the most critical piece, the network. Why does that network matter, particularly in a care delivery environment? And what requirements should you consider when architecting your evolved network? So let's dive into these topics now. As most of you are likely aware, the healthcare industry is in the midst of an evolution. Globally, providers are grappling with runaway costs, less than ideal patient outcomes, and frankly a disparity in access to care delivery. Technology is often looked upon as the means to address these challenges, and we're starting to see that the entire business model of care delivery is shifting on many levels. The industry is moving towards an accountable care model, and we're starting to see this adoption of new care models such as mobile health, remote monitoring, telemedicine, and EMRs come to light. I'm sure each of you can attest, no pun intended, that one of the most ambitious undertakings is to digitize patient records. Of course, by making this patient information digital, it becomes much easier to share. Certainly, improved collaboration among care providers and even between patients and clinicians would help outcomes and efficiency tremendously. Digital records can also facilitate better data aggregation and analytics. The ability to extract these trends and insights will certainly propel care delivery into the modern era. You couple this desire to collaborate and aggregate with the desire for anytime, anywhere, any device access to the data, and we start to see this engine that's driving the evolution of the healthcare business model. Well, as you know, your job as IT professionals is to implement the systems that deliver these new models, while also balancing them against patient privacy and security, compliance, and regulatory measures, right? Not an easy task. Well, as the business of healthcare evolves, so too must these underlying systems that support it. You know, gone are the days of the distributed client-server model, dedicated server farms, and purpose-built SANs. You and your teams are implementing virtualized compute platforms that are much more scalable and efficient. You're implementing cloud services that are providing flexible, ubiquitous access to the data, and you're supporting more of this centralized data model with thin clients on the edge like mobile applications on tablets and smartphones, and you're mapping that to corresponding large data sets, otherwise known as big data, in active data center environments. These are certainly modern IT systems. Now, as these compute and storage platforms have evolved, so has the network. Outdated network and security equipment coupled with legacy designs just will not support the next era of health IT. You've likely already experienced things like EMR performance issues, problems providing the right type of Wi-Fi access for a variety of users like patients, administrators, clinicians, or dealing with painstaking complexity due to isolated, purpose-built networks, each designed to support the specifications of one medical device. And that's manifested in sometimes physically separate networks or even just hundreds of VLANs. But the point is the complexity is very limiting. The point I'm trying to make here is it doesn't have to be this way. When you're considering how to evolve the health IT network, consider 4 requirements. Performance. Clearly, the network has to be high performing. And this means in the most mission-critical environments, we simply cannot drop a packet, even for the wireless infrastructure. If you're carrying sensitive patient data, like a heart monitor, for example, you would not want that packet to drop the moment that patient's heart stops beating. Obviously, this is as critical as the mission gets. You also want to consider scalability. This environment has to be flexible and agile. It cannot be fixed, so it has to have the ability to grow organically as the needs evolve. Ultimately, it also has to be simple. So when you're considering the network, consider how to scale it down to one general purpose IP infrastructure that is simple to manage. And obviously, we're all trying to reduce costs here. Total cost of ownership should be part of the package. Not only the upfront cost of the capital expense, but also the overlying life cycle management of the platform, the operating expense that goes with it. These are the requirements LURIE considered when they were building the new hospital that Ron will talk to you about shortly. They selected JUNIPER'S vision for network-enabled patient care. This is the idea that the network can have an enabling effect on caregiver mobility. It can better connect the ecosystem of people and machines that are generating the data and analyzing it. It can also provide a platform that grows and scales as the new care models come online, and table stakes. It has to robustly safeguard the patient data. So with that, I'd like to turn the floor over to Ron Isbell. He is the Director of Network Infrastructure at LURIE Children's Hospital in Chicago, and he'll explain how he and his team leveraged our vision to build their new state-of-the-art children's hospital there. Ron?
Thank you. Okay, terrific. There are a lot of things on the slide, quite busy, and the participants can look it over. I'm going to talk about a few other things that are not on the slide, actually. This project for us was a 3-year project to get into the new hospital. Starting out with a very intensive RFP design, and all the way through selection, then additional design, staging of the new hospital, certification for medical applications, and finally installation. A very exciting day when we moved in. We actually moved 300 patients 3 miles across the city of Chicago. They shut down main avenues in the city of Chicago, and it was really a parade of ambulances, all hands on deck. It's been an exciting go-live. What I'd really like to talk to, though, is some of the features in the new hospital that couldn't be included in one slide. Some of the neat things around family services, some of the additional features and some of the medical technology in the new hospital. I'll start by saying it is really a cool place. You know, I started out building it. We got in with the cable plant when the concrete was being poured, and to see it transform from a skeletal structure and foundation to what it is today was really something that I obviously had not seen before in my life, and I think few people really would see that way. But it is cool. For family services, we've got things in this place that are pretty remarkable. We started out with a board of children, actually, telling us what they wanted to see in a hospital, and we actually listened. And pervasively, from a child's point of view, what they wanted to see was they didn't want to be in a hospital. And, that seems very obvious now, but, when many people design medical care facilities, they don't take that patient into account like we did. And, it does feel like a hospital. This place really, as much as possible, does not. We've got things like on one floor on 11, there's a whole fire truck. There's an actual fire truck that was lifted into the building before the skin went on. It was only to get on, and it's fully featured and outfitted for the children. They can go in and work the controls and have quite a bit of fun on that, and that's very popular. Another cool feature, on one side of the building, you'll see even from this drawing a children's hand that spans about 3.5 floors of the hospital. That's actually hooked up to a computer system. A child in the day can design the lights and the syncopation of the lights and really look and feel the outside of the building. And then additionally, we film that from across the street from the roof of the Museum of Contemporary Art. That's turned into a CD or put on digital media, and the child can take that home. So, they another feature they greatly enjoy. We've got a beautiful sky garden, and something kind of interesting about that sky garden is the wooden benches were donated, and that wood actually is historical. It comes from the 1880 Columbia Exposition in Chicago. It was planted by Olmsted, those trees, many of which do not exist on the earth anymore. When those trees fell, they were archived, and then some of those were donated to us. So some really cool stuff. There are interactive educational and fun features throughout. We've got a learning center so the children, many of our patients are in the hospital for a duration of time, and we've missed out on education class. They can do distance learning, and there is an instructor on premise. The Museum of Science and Industry have donated many neat things, as well as the Adler Planetarium. There are interactive wall features and things that kids can play with. There's actually an Airstream bus in one of the waiting areas where it's kind of camping. There's a fake fire and real camping experience and other neat things. Technically, we have IPTV, HD IPTV, with a company called Get Well. So when the child enters the room, the TV station's programmed for them. It welcomes them. There's actually prescriptive television based around the child's particular healing condition. So the child, in a fun manner, can interact with the television and learn a little bit about what the recovery might be like. There are features for parents as well to check in on scheduling and such right on the television set in the room. Another thing I found cool, our pneumatic tube system is actually on the network. And that's used for proper and expedient delivery of medication, also for controlled medications to be delivered to the specific nurse who has the credentials and can legally gain access to that medication. So we don't have the controlled med carts on our floors. That's all handled through the computerized pneumatic tube system. Another cool technology, we have a nurse call integrated and communication system specifically designed for nursing. They've got handheld devices. They can go and essentially hooks up with our RFID so they can see on that device when a patient needs them. They walk into the room. The light goes on and off as they enter, and what's recorded is what type of nurse was in the room, for how long she's been in the room, and there are features assimilated with that visit. So, but that nurse call system on that handheld device is something that we've learned that the nurses really operate around. With the layout of a high-rise building, it's not lengthwise, so the nurses quite often do not have, most of the time, they don't have line of sight of themselves, of each other, or the nursing station. So, they use that. They can text off it and call each other off of it and call care providers in an expedient fashion. And they really use that to, handle the situations and be able to staff appropriately and respond to patients appropriately. When that doesn't work, we hear about it right away. It is the most important application in a nurse's life. A couple other things. We've got pervasive bedside monitoring, and that's on a handheld device as well, so the patient's condition from the bedside can be seen from many locations. Tons of different patient telemetry applications and diagnostic applications. Another neat thing we're doing out of our data center within the building is we have a community outreach program, Community Connect, and we really function as an ASP provider of our electronic medical records to different physicians in the community. Really neat stuff, and done on that Juniper network. But those are some of the things I want to talk to the slide, and obviously during the question session, if there's something I didn't touch on and you're curious on, I'd be more happy to talk to it.
All right, thanks, Ron. I'm just going to go a little into breaking down the badge that the U.S. News and World Report awarded to LURIE, and then I'll kick it back over to Ron to go more into the hospital details. So the slide you're seeing breaking down the badge of the top pediatric hospitals in the nation, which is ranked by U.S. News and World Report. So in the 2012-2013 season, LURIE, after the new hospital had opened, was very excited to announce it was ranked as the 9th best pediatric hospital in the nation by U.S. News and World Report. So what this means is the freestanding children's hospitals for large multi-specialty pediatric departments of major medical centers, which means they run as if they were a hospital or within a hospital, are ranked by U.S. News and World Report. So the specific mission of the Best Children's Hospital rankings is to identify hospitals that provide the highest quality of care for children with the most serious or complicated medical conditions, using the most robust and sensitive measures available. So these rankings are based on 3 things. 1, patient care resources. 2, treatment, patient safety, and reputation. And then 3, patient outcomes. So out of over 5,000 hospitals in the U.S., only about 1 in 30 actually has the quality expertise to care for children with serious problems. So these rankings really encompass, everything Ron was just touching about in the hospital. This all goes into these rankings. So LURIE, along with the other hospitals, is ranked in 10 specialties of the national program. These include urology, nephrology, cancer, orthopedics, neonatal, cardiology, and a few others. So in addition to being the 9th best pediatric hospital in the nation, LURIE was ranked on the honor roll, which means out of these 10 specialties, you need to rank with 3 competitively against the best hospitals in the nation. So LURIE specifically was urology, nephrology, and gastroenterology, and it also ranked in all 10 of these specialties individually. So LURIE is the only pediatric hospital in Illinois to do so, and it is ranked in all 10 of these specialties. So these rankings really could not happen without the state-of-the-art infrastructure that supports the hospital, really the backbone of the mission-critical network. LURIE is committed to providing the highest quality of care in over 70 specialties. So the ranking is really a testament to that promise and everything that goes into that promise. So I just wanted to give a quick review on that, and then Ron, I'll kick it back over to you now to go over more of the details of the infrastructure.
Okay. So there are a couple things that I'd really like to highlight on this slide. I could talk about this for a long time, but I'm not sure how much time we have. But a couple of things. One is the network convergence. When a lot of people build a new facility, it's common to put in, many separate networks for the phone system, for the IPTV system, security cameras. Certainly the medical device vendors, the patient bedside monitor vendors, and some very leading vendors in the industry, they want to put in a parallel, their own separate network. And that was not our goal. Our goal was to have one network in the building, a Juniper network, and one network only. And we were able to achieve that, and at times we'd have some kind of interesting stuff. You'd have medical device vendors come in and say, and large vendors say, come in with a bid and say, this is how we do it. It's a separate network, and, end of sentence. And then somewhere along the bidding process, when they found they were going to lose the bid over a competitor that, was a little more able to integrate, they change their tune and say, yeah, no, we actually can do it on a customer-supplied network. And, what they hand us hope for that is they can do it, but their technology is really 1990s technology. They need layer 2 adjacency. They want, layer 3 interfaces to the core of your network on, proprietary series of switches with no loopback prevention, meaning that, they would be willing to cause a nightmare for everyone by a single broadcast storm taking down your entire network and things of that nature, and the list really went on. So, we met the challenge. We were able to provide different solutions and adjust the network in different ways to accommodate. Similar to security cameras, elevator controls, many of these companies, hadn't been challenged previously to work on on a single network, on a converged network design. Using virtual router technology and other mechanisms, we were certainly able to achieve that goal. So again, there is one network in the hospital, one Juniper network. The goal was to do that for two reasons. One, most obviously and foremost, was the expense with running in separate cable plants for all these networks was into the millions of dollars, and we didn't want to do that cost avoidance. And then secondly, though, it was really about data interoperability. Disparate systems on separate networks simply cannot, combine data into, one experience. And we are finding more and more, constantly a vendor that said, no, we need to be on a separate network, is coming back around, and we're coming to them and saying, no, but we actually want to put your data, we want to integrate it, combine it using, interface technology and, data combining platforms. So, that's gone very well, and we're able to progress into the future, due to that converged network design. So the other thing I want to talk about really was the security. Data security in the new hospital. We started this out, 3 years and actually 4 years and 5 days prior to this conversation. I have a big background in data security, about 16, 17 years into that discipline, and I saw a few things. One, I saw that we had a separate network infrastructure team. The switch route people were basically isolated from the security people, and they sat in the same room and all that, but really, during projects, initiatives, troubleshooting, it was, well, that goes over to the security guys, or well, that's a switch route problem. And my vision was that would not support us into the future, and I was really looking for an integrated security design, baked-in security design. And the way we achieved that actually was first culturally combining those teams, educating providing the same education around the new network to both teams, and then finally combining the teams under myself. And today it's network and security teams. I'm not saying that people are completely interchangeable. They certainly do their specializations, but they very much understand that you cannot move a packet, across the network without passing through some type of security mechanism. Additionally, the security guys understand that what they do, has to be pervasive throughout the team. There has to be communication, and they cannot prohibit any type of traffic design or network design. So we did that with 3 different technologies. We have an integrated firewall pair linked to the core. So that firewall is again a security control that every packet in the network goes through. And then the policy on what we use for STRM, which is our SIEM, really is dictated by another technology we use. We have pervasive unified access control. What that means is that at the wireless and wired level, you do not get on the network. You cannot attach a device to the network without that device being authorized. We know what it is. It's authorized to be on the network, and we know the state of the device. So that really does guide our integrated security, strategy. So, the way we do it is we, like most companies, we cannot turn all of our facilities. We have about 20 facilities, small, medium, large. We couldn't do them all overnight. We did 4 major facilities with this new hospital go live, and those securities have the new, 802.1x-based security control. So the internal firewall pair inspects traffic, but it also is a WAN block for one of 2 hubs on our campus environment, one being the data center within LURIE where many wide area network connections come in. And it works so that if a connection comes in from a location that is 802.1x, we know what's on the network, we know the state it's in, that traffic will be inspected but not necessarily blocked. If it is from a location that's still legacy, still awaiting us to refresh it with the new technology and security design, that traffic will be inspected but also be IDP'd. So, all the technologies kind of work hand in hand together on a security basis to, to design our strategy and keep LURIE a very, very secure children's hospital. So I'll turn it back over to, I think, David or Tim.
Thank you, Ron. Appreciate it. Good morning, everyone. My name is David Anteles, and I am the Director of Architecture for Maron Structured Technologies, and I am also the lead engineer and team lead for this build at Ann and Robert H. LURIE Children's Hospital. First of all, thank you to Robert and LURIE Hospital for allowing us the opportunity to work on the hospital and provide this unique experience to the children and to the clinicians and physicians and all of those that make the wonderful magic of healing possible there at the hospital. It truly was a pleasure, and it truly was an honor to work on such a greenfield project. So how do we take performance, scalability, simplicity, and TCO and marry that with functionality and integration within a large organization and then turn 1.25 million square feet, I'm just going to move over to the next slide, square feet of concrete, drywall, studs, etc. How do we marry all of those together and come up with a architecture that is both usable, simple, and then able to provide everyone as far as the requirements that are needed. So we take a look at the environment in and of itself. So as Ron alluded to, virtual chassis, the Juniper virtual chassis environment was used to create the environment. 40 gig backbone with virtual chassis, over 3,000 plus ports. It's spanning tree free architecture, security all the way through from an 802.1x perspective, all the way from IDP to logging. All of those mechanisms were put into play. However, the things that we had to make sure that we complied with were the requirements that Ron and his team put forth in front of us, and that's being able to make this a pliable environment, one that can be plumbed for multiple applications as well as multiple vendors. It's very key and very essential to understand that the vendors have a specific set of requirements. Also, the applications have a specific set of requirements, and all of those, when they come together, can help deliver the mobility, can help deliver the security, and deliver the usability within the environment that was being proposed. So with 4,000 plus users and 15,000 plus unique elements as far as authentication, it was very much necessary for us to understand everything that went on soup to nuts from the environment. So as Ron stated before, 3 years in the making of this hospital, it was a requirement to go in there and say, ask the tough questions on how do we use this environment, how do we use the applications, what are the specific use cases. And in designing that, this resilient, highly available network, it was also our responsibility to come together with those applications and with those vendors, as well as our partnership with Juniper. This is where the rubber met the road as far as being able to build out. Just about any integrator can go ahead and take a platform and put use to it. However, being able to ask the questions and understand how those applications and what the application should look like and baselining these things so that we can have a usable and much more predictable environment, I think that speaks large for both Juniper as well as Children's Hospital in being able to work with us and provide us the answers that we needed in order to get this thing done. So we take a look at some of the architecture and some of the devices that were used on the environment. So we talk about SRX security gateways. Those are the head ends, the layer 3s for a majority of the traffic, especially voice and then some of the multimedia that's going on between the different sites. So Children's is built out with a centralized location, which is the Robert H. and LURIE Hospital, downtown Chicago. They also have facilities throughout the Chicagoland area, as well as partnerships with other hospitals in the region. In order to safeguard traffic, and mitigate any issues that might crop up from partnerships and whatnot, we had to make sure that we designed the environment so that it was an environment that was, one, scalable, an environment that was secure, and an environment that was highly available. One of the mechanisms that we used with it that were route maps and filter forwarding, especially when it comes to PACS. So Children's does have relationships, as I said, with other hospitals, and they do a lot of sharing of medical imaging. And the requirement there, too, is from the opposite side, is to protect their data from the medical imaging information that's coming across so that networks remain separate. That is a key component to the integration as far as making the partnerships viable and still productive without slowing down the information that's coming across the WAN. The other thing that we integrated was ISG integrated security gateways, in other words, from IDP. IDP is very essential in the environment and understanding what is going on and being able to provide the ability to watch the information and report and log against it. As far as security is concerned, and remaining HIPAA compliant, it's always important to understand who's accessing the data, when it's being accessed, and how it's being accessed. And that's where that comes into play. As far as the resiliency and the redundancy, I'd like to talk a little bit about it and how we're doing that. So every device, including the SRX, is basically clustered in a high availability mode. So what that means is that the data is shared across the multiple platforms between each other. So as Juniper provides a forwarding and routing plane, a separation of those two functions, it allows the devices to pretty much stage each other up. In other words, share information. So the configuration is propped up on one box, and then it gets proliferated down to the other adjoining appliance. So what that does is it allows for the information to be shared between the two boxes, and then in the event of a failure, the other box, the secondary unit, is able to carry on and carry forward with that information. Now, what does the segmentation or the separation of forwarding and routing do for you? Well, in the event of downtime, so any of your routing processes, such as OSPF or BGP, those remain constant and up and static because the information is forwarded and stored onto the forwarding box or the adjacent appliance. And what that means is when the primary fails, the secondary will take over with the information because the table's already been forwarded, the information's already been passed along, so there isn't a hiccup as far as the failover is concerned. Virtual chassis allows us to maintain uptime because we have dual routing engines in every IDS. We also have dual routing engines in every core switch that we employ. How does that impact the environment? In the event that a floor were to have experienced issues with the routing engine, the other routing engine, very much like that of the SRX, takes over. The information again is forwarded to the adjacent routing engine and always kept in state, thus allowing the information to be kept and forwarded and resilience. So the event that the primary goes down again, the secondary takes over. As Ron also talked about, we also have the STRM, or the Security Threat Response Manager. And that is the single pane of glass that we use in order to manage and watch and monitor all the security information and event logging, especially flows. It allows them to remain compliant with HIPAA and being able to understand, again, who is looking, who is touching, and who is accessing, and how they're accessing the information. We also have the implementation of managed services. So as Maron, as a component from Maron, we provide 24/7, 365 days a year monitoring of their environment, and that includes everything from their switches, switches, routers, and all of their security appliances, as well as any devices that are attached to the environment. So that gives us the ability to alert them and provide them with a mechanism when one is not available to be able to be proactive in order to respond to issues. So the next slide over is one thing I really do want to talk about, and it involves the partnerships with Juniper, with children, and with all the vendors and the application vendors. The value of being flexible. It's one of those things that helped Maron in the onset to be able to design and put the environment together with the understanding and collaboration. It was a requirement from children that we have the ability to provide access for all of these different vendor types, everything from infusion pumps to elevators to security mechanisms and security cameras and Wi-Fi, etc. Understanding the need and then being able to go out and collaborate with those vendors is equally important as much as the initial design. The other thing is working towards a common goal. I think we as a unit, we came together providing each other with responsibility, assigning responsibility to each other as far as who's responsible for what component and how we're going to deliver the environment. It's one of those things when we talk about open standards and how open standards actually provides for a much easier platform to integrate. That is absolutely true. In working with Juniper and being able to utilize that open standards approach, it was easier to integrate a lot of the other components, such as Philips or Polycom, etc. Those vendors, and integrate their systems into us. It wasn't that we didn't try to dictate to them, you're going to change your way of doing business or your way of how you shape that packet and integrate it into our system. It was the flexibility, it was the openness of the environment that allowed for that to happen. And then we built this trust relationship. Trust relationships between across parties, across members, one between Maron and LURIE, between Juniper and Maron, and then again between the partnerships between the application and the independent vendors. And then we all come together and then we understand what the lessons learned are. And we understand what the support mechanism needs to be and how it needs to be put in place, what needs to occur from a response from our managed services team, and then the knowledge that we provide to them and how we transfer that knowledge. All of that culminates together for a completed and successful build. And again, this building is a very unique building, and the magic that happens inside is equally as important to the magic that it took to get there. But all of those clinicians and physicians and nurses, using the technology in each and every day, we understood that, what the importance, and we stuck to the importance. We stuck to what was important, what the goal, the ultimate goal was, and that was to deliver the children a unique experience. At the end of the day, when you're putting together a large building such as this, it's easy to get lost within the constraints of each individual technology, and then not be able to marry those technologies together. With Juniper's partnership and with the partnership between Children's Hospital, it was easy to put it together because we had one common goal, and we were able to work towards that common goal and then shape that common goal into a strategy. And from that strategy, it became an implementation. Ultimately, that day, that last June, when the 300 plus children were coming in. I was there that morning, and I was there to see and able to see, the validity and being able to have that feeling of completion, that mission accomplished. We were able to provide a hospital that delivers beyond expectation, for both the staff and the children. So with that, I'd like to present it back to Ron, who will talk about some of the future initiatives that we're working on at the hospital.
Thanks, David. And yeah, David was actually standing next to me for much of that move-in day. Quite a hectic day, but again, that feeling of mission accomplished, we did it, was all there, and it definitely was through that partnership and the ongoing partnership with Maron through their support organization and their implementation services. And we do continue to grow, do continue to add new technologies into this network. So, some of the things that we look at, now and for the future, I mentioned a little bit about the Rural Healthcare Network, and what that means to us. So, the state of Illinois has really challenged healthcare providers, and certainly through the Accountable Healthcare Act, to, move this technology and certainly the medical specialties that exist in the city of Chicago throughout the state. They have built and have been building really what started out as a research-based network where all the major hospitals that, are academic, and we are obviously patient care. We've talked a lot about that. We're also an academic institution. We are the pediatric academic arm of Northwestern's academic program. So if a pediatrician says, I did my residency, my fellowship, my education through Northwestern, they really did it at our hospital. And again, we are that arm. They are taught and at our facility. We are a research institution. We have a separate research center for bench research, and then throughout the hospital, we have child-based research or patient health-based research. Ranking in the nation, we are among the top 10 pediatric research institutions by NIH grants, in the country. So, all of this combined puts us on that research network, all fiber-linked, with many other research hospitals throughout the country, and certainly throughout the major Chicago metropolitan area. What the state of Illinois is looking to do is to hook all these hospitals in and then provide that fiber throughout the state. And they've had a program for quite a few years to provide fiber into rural settings and smaller communities throughout the state. Now they're coming to us, and it's part of that act. Really, the federal government is driving through the state government as well, that we start linking in and providing consultative services, throughout that network. Certainly have had, David's been part of many design sessions, and, his team, and, we are looking to very rapidly join that and fulfill that mission and goal on the federal and state level. Data center scaling. It's interesting, today I'm actually in Sunnyvale, California, at JUNIPER'S headquarters, and it was an executive briefing session particular to us. And we talked to some of the lead product managers, the CEO of JUNIPER, and others about what we're going to do with our data center moving forward. We do have a dual data center model, active-active. One is, as I mentioned, in the facility. The other is about 20 miles away at a off-site colo location. In healthcare, it's kind of interesting, too, from a DRP perspective. Many people say, well, your second data center is probably DRP, but it really doesn't work that way. If we have a major incident in the facility such that we have to evacuate the facility, that's kind of, end of game for us in a sense. Many businesses, financial services, somewhat manufacturing, other industries, and, okay, well, this facility's down, let's move all operations to the New York facility or such. Again, we're patient care based, we're inpatient based mainly, and, we can't do that. So, the role of IT in that situation, isn't one of DRP and recovery. That certainly might happen later, but it's not the situation as in many industries. Our goal is to have data fully replicated across both data centers. We're looking forward to doing load sharing when the resources are needed and available in a different data center. they can be quickly shifted over seamlessly to the end user in the application. So our next goal is to refresh our second data center. We're having many conversations around QFabric-based and the new EX9200 line with the SDN capabilities. And really what we came to is, it's kind of a combination of both for various reasons. QFabric, if you're doing highly virtualized environments to get those speeds and feeds, is the right solution. An EX9200 based core, for us makes a lot of sense. And the ability in what's coming up with Juniper that you'll see, perhaps, is, well, not perhaps, it's a matter of time, but the hybridization of those technologies where they interoperate together, where virtual chassis can work between a QFabric-based top-of-rack and traditional EX series top-of-rack. And I think the industry is going to go that way because I think we're seeing needs in both directions. And again, the SDN approach as well, it can actually be married in the future is my belief. So I'll hand it back.
Okay, I guess it's time for Q&A. So thanks to Ron and David and Jen. And before we begin the Q&A session, I'd just like to please remind the audience that they can submit questions by typing them into the questions box and clicking submit. First question for you, Ron, is with you having a primary and secondary system in case of failure, if failure to secondary, do you eventually move back to primary or leave, and how is your data stored for both?
Sure, that's a great question. And so at the network level, we, again, David had mentioned we have a highly available network. There isn't really any device other than at the edge, and even the edge is, virtual chassis technology, but all the main components of the network, and it is a large network, are replicated on, both on 2 different floors of the hospital, about 6 stories apart. When we do have a failover event, for one, I'll say the failover events that we've had are noticed by engineers, not by our end user community when it comes to network core systems. We do have maintenance windows, being a hotel-like facility, 24/7, just doesn't shut down ever, including holidays. We have maintenance windows that we have predicated with the organization going into this. They're not good hours. They are Sunday mornings being 2 and 4 a.m., but that's what we coalesced on. So what we will do then is have a failback event into the next available maintenance cycle. As far as the data goes between the data centers, much of that is application-based. We use Epic as our main EMR, and that system has application-based journaling back and forth within seconds. So those failbacks can be tested annually as well, and have been successful there. So I hope that answered the question.
And Ron, what guidelines did you follow in determining an appropriate location for the second data center?
That was much prior to we've been in that second data center for coming up on, we're into our second 5-year contract, so we've been in that second data center for 8 years. And again, 8 years ago, I remember we spent about a year doing RFP, and then visiting, I think we started out with about 15 different ones. In Chicago, there are a lot of co-location data center, opportunities, and we did vet all those. So, it was a combination of different success factors we were looking for. That second data center is our ISP, and, in a connected world and all the remote initiatives we have in healthcare, telemedicine, and others, we needed a very highly available, from an ISP perspective, data center. So that cut a few of them out right away. We needed to see an organization that's been into data center as a business for quite a long time. So we did then further cut it down to only leaders in the industry. And then of course at the end of the day there were service level agreements and things that we needed to see. We needed to see proven SLAs on. We needed a data center that was scalable. We needed a data center with plenty of room for growth. And then lastly, of course, it was pricing. So we did have a shootout amongst 2 or 3 of them actually, and who could do the business right, and then who could do the business cost effectively.
Great. someone else is wondering, was a master data management strategy included as part of the infrastructure implementation at LURIE? And could you please discuss how connectivity, mobility, and security is managed?
Sure. So, that we do have a very I'm going to say very good informatics program. So we've had those people. Being an academic institution, you can it's kind of a double-edged sword. So we have a lot of very analytical thinkers, a lot of people with a lot of great ideas, and a lot of what I'll call Imagineers who want to see things their way. But at the end of the day, it is a consensus organization. I'll say that, and they're very good at coming down to a final point of considering all opinions. So master data strategy, if I'm reading the question right, again, our main EMR being Epic, we interface to that, and all the different data, warehousing techniques and all that do center around that. And Epic certainly does provide for those capabilities. As far as managing the various different mobile devices and all that, obviously one point is security, and again with our integrated security model, we have many different layered security technologies, and that they can inspect traffic and handle traffic, segment traffic correctly. We do rely on mobile device management vendors. We are a huge Citrix environment. We are role-based access, so we have an enterprise portal. That is served by Citrix. We have 360 distinct job roles. It took about 5 years to map the organization to their application needs, and things are provisioned along those lines. So when it came to mobile device management, it just made sense for us to go, with a Citrix-based solution, and the management, all that throughout that. So I hope I answered the question. I'm not sure I understood it correctly, but I hope I touched at least partially on it.
And could you talk a bit about how clinical and operational staff were trained and sort of transitioned into this new digital environment?
Yeah, that's a great, something we didn't touch on. We have 300 applications, and we consider everything an application in a new facility. Anything from your traditional web-based application down to, the building automation control systems, the suite I mentioned, but there are 300 applications running, in our environment, facility-based and then, traditional application-based. Going to the new hospital, over 40% of the applications and the technologies were new, or brand new. So obviously, in a care provider scenario, that's huge. A clinician that does something one way, today, in a cutover situation, saying, well, tomorrow you're going to do it differently, won't work. So we did start about a year out from the go live, educating, the selections for vendors, and there were a few that crept in, at the nth hour. Certainly always will happen in a greenfield environment, but really about 90% of the new applications were known within a year, and that was a goal set out. And then the education on those new applications started. There was a learning curve, but I don't want to say surprisingly, because we didn't want any surprises, but it did work very well, and we found that go live in the weeks leading up to it, and certainly the time after it, has been highly successful.
All right. Well, thanks, Ron, and thanks, of course, to David and Jen, and to everyone in the audience. In the meantime, thanks to everyone for joining us today, and if you would like to view the archive of this webinar or share it with a colleague, please visit the on-demand webinar section on healthcareitnews.com. Thanks again, and have a nice day.